about so far. If you are a person that is not had a lot of experience using an IO needle before, it can be kind of scary. You're drilling into somebody's bone. There's been studies done that allegedly a IO to your leg doesn't hurt any more than an 18 gauge in your arm. I haven't been willing to test that out. I've tried to talk a lot of people into it and no one has volunteered yet. But allegedly that's the case. In my opinion, which is just my opinion, if it helps anybody, great. If it doesn't, kick it to the side. IOs are one of those things that you have to do it. You have to bite the bullet and do it. The only way to get comfortable doing IOs is to do them. If you never do it, you're gonna freak out every single time you have to do it. I have watched people put that needle and drill to someone's leg and then just drop it because they can't do it because they're scared. And that's okay, and we can help you through that. But the only way you're gonna get better at doing it is to do it. When I started, we used to do IOs a lot. Since we have started doing ultrasound IVs, it has kind of decreased the amount of IOs and EJ IVs that we use. But if you have somebody, especially somebody that you're really worried about in a code situation or that has a blood sugar problem, and you poke them a couple times and you can't get a line, drill their leg. Because you can get what you need, you can keep them alive and keep yourself from having to do CPR, hopefully. And I would just encourage you that it's one of those things, and that's something we're going to talk about when we talk a little bit about epi here in a moment, is that if you study and you know what you're doing and you're competent and you're following standards of care, it's okay to be maybe a little bit more aggressive or trust yourself to do the right thing because it could help save you from having more trouble down the line. And IOs is one of those things. I didn't love them. I was always kind of nervous about it. Personally, when I started working for Air Methods, they really pushed that on us. If we didn't get a line, we drilled in their shoulder. And the shoulders are a lot trickier than legs, in my opinion. But after I did it multiple times, then it was no big deal. You just do it and knock it out and you can get done what you need to. So just something to keep in mind. My focus today that Dr. Christian asked me to talk about was there's some questions about epinephrine administration and in anaphylaxis cases, which is kind of most of the time that you're going to be giving epinephrine is somebody with a bee sting or some sort of allergic reaction or anaphylaxis. Somebody who didn't realize that they're allergic to shrimp and they eat a whole bunch of shrimp with their family and then they show up freaking out because they can't breathe. The case that came to mind for me the most, I was working in Safford not too long ago. There was a family who had a pest control type company. They had gotten a contract to work at a hotel in Safford, and they were trying to get rid of some bees that had found their home at this hotel. And so there was a mom, 2 sons, an uncle, and then a friend who was just helping run a lift because some of the bees were up in the lights in the parking lot. So they show up front, they pull up to the front of the ER, freaking out. The one son still had a bee suit on with tennis shoes, which is a kind of a dead giveaway that maybe these aren't the people that have exactly idea of what they're doing, but I think they were doing their best, which is great. So they come in, they're all freaking out. All of them have a whole bunch of bee stings, and it was very interesting. They were panicking, and I think that all of them together didn't help anything because they were feeding off of each other's energy, and the mom was worried about everybody else. The friend who was just helping was really the only one who was kind of calm, but maybe that was because the rest of them weren't his family. Something that was important to remember on that luckily we caught before it got out of hand, the guy that was in the bee suit was complaining that he was still getting stung. The triage nurse brought all the patients back to rooms to kind of let them in. So here, you'd have the people show up to underneath the awning out here, and if the person is complaining, you want to think about environmental things before you start getting into other things. Just as this guy gets to the room, he starts to get ready to take off the bee suit, and luckily someone thought about it and made him go outside into the ambulance dock. And as soon as he started taking that bee suit off, you could see on the camera, on the security camera, you could see all the bees fly out of there. So had he started taking that thing off at the bedside, then we would have had a bunch of bees in the ER, or you'd have a bunch of bees in this urgent care, which would literally be a disaster. That would not be good. So something to, things to think about, especially in this situation. If you've been in EMS or different things, some of your training, always remember, you joke sometimes, you're like, I have my PPE on and my scene is safe before you start doing any patient care. So just something to think about. So these guys were all freaking out, which didn't help anything. We got them into bed, got them on a monitor, and started to do everybody's assessment, try to see where we were at. And all of them were having pretty good reactions. The one son that had the B suit on, he was not doing super great. And so he needed, more action than everybody else. Ended up being that the reason I thought about this one is that each person kind of needed different things. The mom didn't need a whole lot. The one son in the B suit needed quite a bit. The other younger kid, he needed quite a bit of medicine. The friend that was helping and the uncle, they were pretty much fine. Another patient that I had not too long before that, there was a guy at a gas station drinking his soda, talking to his buddy in the parking lot. No big deal, everything is fine. Never had an issue with bees before. A bee went down his straw in his soda. He took a big drink of soda and the bee stung him in the back of his mouth, kind of near his uvula. And he, obviously spit the bee out, didn't enjoy that soda much. Thought he'd be fine, talked to his buddy, and then it only took a couple minutes for him to start to realize he might have a problem. By the time he got to the ER, you could barely see down his throat. When he opened his mouth, everything was just swollen. And so that obviously was something that was pretty darn concerning too. So anaphylaxis or allergic reaction treatment, something all of us have done before, but in review, you're going to have kind of 4 main medications that you're going to be giving. The first one is Epi, which is the one that we sometimes can be a little concerned about or worried. You're going to give Benadryl, a steroid, dexamethasone or Solumedrol is probably going to be your most common one. Here we have both of those. And then you're going to give ranitidine or famotidine. So Pepsid we have here, we have PO Pepsid, we have IV Pepsid, we have PO Decadron and IV Decadron here, and we have Solumedrol, and of course we have PO and IV Benadryl. The things to remember as far as medications go on those patients is it depends on the patient, okay? You'll have all those things that you'll give. Most cases, 95% of those times, the epi comes at the end, but it's important to remember that sometimes the epi might come in the beginning. That family, all of those, every single person in that family or crew or whatever you want to call them, they all got Benadryl, Solumedrol, and Pepsid. And then the 2 younger guys, the one in the B suit and the nephew or cousin or whatever he was, I can't remember, he got epi also. The guy in the B suit, the first medication that he got was epinephrine in his leg because we were kind of worried about him. The guy who had the bee in his soda straw, the first medicine that he got was epi in his leg because we were pretty worried about him. Sometimes I think there's a bit of a stigma when we're treating these patients that even from some providers that I've worked with, and especially from some of the nurses, we get kind of nervous or standoffish about giving the epinephrine. And I get that, it's kind of nerve-wracking. We think of only giving epinephrine in a code type situation to try to get a heartbeat back. But once again, kind of like I talked about with the IO situation, if you know what you're doing, you're competent in your skills and the dosing and what that medication does, it can be one of your best friends. If you have a patient that you're really worried about getting bad, that you think you might have to intubate or something might have to happen, giving them that epi can be huge, and it can avoid lots of problems down the line. The guy who sucked the bee up his straw, we intubated him anyways, but it ended up hopefully being less bad because we gave him that epi right away. We gave him epi right off the bat. We were able to talk to him, get his history, find out if he had any allergies to medicine. He had no family with him. He drove himself. And had we not done that and just gave him Benadryl and Solumedrol and Pepsid and hoped that he would get better, then he might have gotten worse and we might have not got any of that information from him. It can be nerve-wracking, but I will tell you from my experience, because that's what I can go off of, that there's been plenty of patients that I felt confident in giving them epi right off the bat, and it made a huge difference. And it made me feel a lot better. It probably made the provider feel a lot better. And yeah, you're stuck with them for a while because you have to keep them on a heart monitor and watch them to make sure they don't go into an arrhythmia, but it's a lot better than having to intubate them or having them get a lot worse. So that would be one thing that I would just say to keep in mind. If you have somebody you're worried about, don't be afraid to give them the epi, because that's what's going to make them better, and it can make your life a lot easier before, instead of waiting, being hesitant to give them the epi could make things way worse. It could cause a lot more work for you in the end. So those are just some examples of people you can think about, and it could be anything. It can be medication reactions, it can be environmental reactions, food stuff, who knows. Here we have epi in two forms. You're going to have little ampules or vials. It depends on how they're getting it. Currently, our epi that is 1 to 1,000 or 1 milligram and 1 ml comes in a vial, or in an ampule, excuse me. So if you remember from school, you got to shake it to make sure all the medicine's in the bottom. Find a 2x2, break it, draw it up with the filter needle so you're not injecting glass into people, because that's rude. And have it ready. Our 1 to 10,000 epi is just what you're going to see pretty much everywhere. That's the epi in the box, or your code epi. And that's what you give people IV most of the time in a code situation. The things that are important to remember is that both of these have 1 milligram of epinephrine in them. It's just different concentrations and different uses, but they can all be used. So in your patient that swallows a bee and gets stung in the mouth, or gets stung a whole bunch of times and says they can't breathe, and you're really worried about them, and you're going to give them epi, you're going to normally just draw from your vial or your ampule the standard dosing, depending on what the doctor wants or what your thoughts are, is 0.3 to 0.5 milligrams, which it's 1 milligram and 1 ml. So that's 0.3 to 0.5 of an ml that you're going to be giving. Most 98% of the times just 0.3. Draw that 0.3 up and give it to them in their leg if you're really worried about them. It'll make a huge difference. You can give IM epinephrine 3 times, just like nitro, but it's 15 minutes apart, not 5 minutes apart. So if you have somebody come in and you're worried about them, and you give them a shot of epi right off the bat. If you have somebody, I've had this personally, I've had people come into the ER and say, I'm allergic to peanuts. Someone in my family tried to poison me, and they put peanuts in the salad or whatever, and they come in holding their EpiPen in their hand, saying that they can't breathe and they think they're gonna die. And you say, did you give yourself the EpiPen? And they say, no. And you're like, great, perfect. So you have 2 options. One, take their EpiPen and stick it in their leg and tell them that they need to do it themselves after they've calmed down. Help educate them to understand that they should have done that. Or you're gonna wanna give that person some epi in their leg right off the bat. If you wait 15 minutes, in the cases that I have seen, people always get better when you give them epi in these situations. So if you give it and then they start to get worse again in 15 minutes, give it again. And then see what happens in another 15 minutes. If they're still not getting better and they start to get bad again, give it to them again in another 15 minutes. And then 15 minutes after that, if they're still not doing better, then you need to talk to your provider about putting them on an epi drip. Oftentimes, education-wise, you'll hear people talk about that you only give IV epinephrine to people who are dead, which I think where that comes from is that people forget about which epinephrine they're supposed to be using, okay? And that most of the time, people who can tolerate it are just gonna get a shot of epi in their leg if they're awake, and they're only gonna get IV epinephrine if they don't have a pulse. But we can put people on epi drips, and we can give them even push dose epinephrine at times if it's what's necessary for their situation. But remember, you can give them, it's not just 1 shot of epi. If they need it, you can give them 2 or 3. If you give them 3 and they're still not doing better, they need to be on an epi drip. And of course, we're gonna talk to the provider, make a plan, and go from there. I took care of a patient here in Morenci with Dr. Sherpa years ago at night. 17-year-old kid, super healthy, no medical problems, no allergies. cross-country runner. He was out running all night, just not for practice, on his own, just for his own training. Running, trips and falls going down this hill, rolls, and ends up, when he stops, in a big ant pile, unbeknownst to him. And he kind of took his time getting up, per his report, to just make sure he didn't break anything or wasn't scraped up too bad. And he didn't realize that there was ants all over him. So he got bit by all these ants, which he didn't enjoy, of course. He said he brushed them all off, thought he'd be fine, went home, told his mom what happened, jogged back to his house, he said, which was pretty far. Told his mom what happened. His mom's like, oh man, that's a shame, go take a shower. So he goes and takes a shower, comes back out, starts to notice that his skin's bothering really bad. Point being, he comes to the ER, or to the urgent care, a couple hours later in the middle of the night, like 2 a.m, and he's just got giant hives all over his whole body. It looked super uncomfortable. We ended up giving him 3 doses of IM epi, because we'd give it to him, he'd get a lot better, and then they would just come back. And then we'd give him to it again, and it would come back. We'd give it to him again, come back. We ended up putting him on an epi drip and sending him to Mount Graham on the ambulance, and he stayed the night in observation. And after he was on the epi drip long enough, it did resolve and got better for him. So it's just something as an example to put the education to a case of things that you can see that could happen. So it's not out of the realm of possibility. IV epi, if it's a code situation, I think everybody knows, you open the box, pop the yellow caps, twist it together, give it to your IV through the closest port, flush behind it so you make sure the epi gets in there. If your fluid isn't running wide open. If you are making an epi drip, sometimes your physicians, especially some of these doctors that we get from out of town, Christensen's buddies, as I like to call them, they may ask you to make a dirty epi drip depending on the situation. If you have a patient that's not doing well, that's hypotensive, that is got a CO2 of 18 that you think is going to start coding any minute, the doctor in a hurry may tell you make a dirty epi drip. What a dirty epi drip is, we'll see if Christensen has a different definition from what I have seen in the past, is just 1 milligram of epinephrine in a liter of normal saline, and you just run it open. So their blood pressure is so low and you're so worried about them that you're giving them fluid to try to bring their pressure up, and you're giving them a little bit of epi too, so that hopefully that kicks everything into gear and helps. And so in that situation, if the doctor asks you to make a dirty epi drip, which is something I could totally see McHale doing, or Dr. Bingham, for sure, you're going to use 1 milligram of epinephrine in a liter of normal saline. And it doesn't matter, it can be this 1 milligram or it can be this 1 milligram. It doesn't matter, they're both 1 milligram. The only difference is the concentration of what you're doing with both. So you can put that in that liter bag, open it up, and hopefully keep your patient from coding. And that's going to be in a situation where it's all hands on deck. You're trying to do whatever you can to keep this person from getting to that point. Sometimes, I think we've had them here in the past, sometimes you might have a big vial. There's 30 ml vials of epinephrine at times that when you need to make a drip, you can use that. And those are still a milligram per ml, just like this, but it's in a 30 ml bottle, which is nice if you're making drips. If you have somebody that you've given 3 doses of epinephrine to, that you need to start on a drip, you can do different concentrations of epinephrine. The chart that I put in the med room is 4 milligrams of epi and 250 mLs of D5. Remember, most of the time your medicines that you're giving that are going to speed your heart rate up, they're going to want you to give it to them with sugar. So on an epi drip, you're going to mix that in D5, and you can do 1 milligram in 250, you can do 4 milligrams of 250, that's my favorite. You can do 1 milligram in 100 mLs of D5 if you want. What's important is to know what concentration it is that you have mixed, so that you can know that when you start that patient on 2 to 10 micrograms per minute of epinephrine, that you're giving the appropriate volume per hour on the pump based off the concentration that you have. So I would recommend just doing 4 mLs, 4 milligrams, which is normally 4 mLs, 4 milligrams of epinephrine and 250 of D5. The other thing I like about that is those are kind of your norepinephrine, or Levophed is 4 milligrams and 250, epi is 4 milligrams and 250, and that's part of why I like doing it that way. It's the same concentration, just kind of makes life a little bit easier. So that'd be my recommendation. we won't go into doing on the pump. If you have questions, Mike's got a great video in the past that Laura has in our records on setting up pumps and doing that sort of stuff. Refer to that if you have any questions. But just in review, to try to wrap this up so that Christian's can get to what he needs to talk to. It's important to know that stuff. I like the fact that we're doing these things. I have appreciated the fact that people have came to me and given me questions to talk about. The end-tidal CO2, this epi question was something that came from someone here in the urgent care who had a question about it. The one thing that I tell people about our urgent care a lot of times is that it's important to think about these sorts of things, because this place goes from mild to wild really fast. 99% of the time it's very mild, and that's part of why I like being here. If I wanted wild, I would go somewhere else, but I don't really care for that all the time. But you will see really sick people here, you will see really hurt people here. Luckily, it doesn't happen all of the time, and when it does, it's going to happen fast, sometimes without any warning. And it's important that you can be confident in your skills and your knowledge, as well as your coworkers, because it might happen at night when it's just Christensen, me, and Logan, and that's it. And we got to know that everybody can do their part so that we can take care of the patient how we need to. And so I think that a lot of this stuff is good. It's important for us to keep it in mind. If you ever have any questions or something that I can help you with, let me know. Remember, IOs, the only way you're going to get better at doing IOs is to practice. You have to do it. There's nothing. You can't drill into fruit or wood or pig bones that they had us do at certain times in classes I've been to. It doesn't feel the same, I promise you that. You have to do it. And the first time you have to start an IO on a baby, you are gonna be in a bad spot. It's not fun, but after you do it a couple times and it helps that baby, it makes a huge difference. Same thing with epi. Someone might come in and you might think, should I do it? Should I not? Should I kind of push the doctor? Should I advocate? That's the test answer question, right? Test question answer. Advocate to the doctor to give them epi. It'll make a huge difference. I would much rather give people a couple shots of epi to be on the safe side and have to keep them in the urgent care for 2 hours on a heart monitor to make sure they don't go into VTAC than have to intubate them and have a giant disaster because we hesitated to give them epi. So keep that in mind. If anybody has any questions about other stuff or other thoughts, let me know. Laura.
I have a quick question. So that's what I was going to ask you. How long are you keeping your patients? Because I don't think that we have that as protocol. So you're keeping them about 2 hours then?
We don't have a protocol. The last thing that I was told, I'll let Dr. Christensen update us or argue if he wants. It used to be 3 hours. The latest things that I have been told is usually a couple hours. An hour for sure, depending on the patient, their history, different things like that. 2 hours kind of is a happy medium of what I feel like. Plan on 2 hours that you're going to.
It's kind of like a racemic epi is the same way.
Yep. Same.
And another question, I just really quick.
Yeah, but not all providers are on that same, off that same book.
True.
I've had providers have me give them racemic and then say, okay, you can discharge them.
Is it okay, Tyrell?
So then you would. My thing that I would say before I turn it back over to Christian is, you do your best. I totally agree with you, Mike. I've been there too. And then something that I think that is good that has changed here is if you have that concern, then make sure you document the patient when it happened and let Christensen know. And if he needs to intervene with that provider and say, that's not how we're going to do things here, then he can take that up. And he's done that for me. And I think that that's a great resource that we have now that maybe we haven't had in the past. So
go ahead, keep going.
I just have another question really quick. So I keep on hearing, and this is just me personally, because I come from the old days, so where we were giving it like sub-Q and stuff. So I keep on hearing in the leg. Is there a reason we're giving it in the leg and not because
Yes.
I have access to other things quicker? I am.
Good question. So the knowledge and training that I have had and the things that I have read, your best administration route for epi, if you're giving it, is deep IM like Phenergan or Benadryl too, or some of those medicines that can hurt and cause some discomfort. So I am always, and I think that So you can do their leg, you could do it in their hip. You have a couple options. I like to always do Epi in their leg, which I never give people shots in their leg. If I have to give them, shots, usually I'll do it in their hip. Is that if this is something that they could have again. So if they have a bad reaction, the provider's probably going to give them a prescription for an EpiPen, and I want them to think that I need to give this shot in my leg. And so if they are that sick and they're that bad, you should be getting them dressed, making sure that you can see everything, give it to them in their leg. You know that you've got plenty of muscle there to give it to them, whether it's a little old lady or a teenager. And then I want them to think too that if I ever have to give this medicine to myself, that's where I'm going to do it, is in my leg.
Thank you. That makes complete
Yeah,
sense.
I think the studies are showing that the vastus lateralis, the side of the leg is the best route for IM because it is a big muscle, easy to hit, and it absorbs faster.
Yep.
Than like the IM in the shoulders or the IM in the butt.
Sure. Anybody else have any questions about anything for me before I get out of here, because I've enjoyed this, but I'm ready to be done.
Is there?
So
we
on
can't
team-
see. Yeah, we can't see
on
the
team,
comments.
Sarah asked, IM versus sub-Q epi. I've done only IM. Do you know about subcutaneous?
So that could be maybe, like I say, that's
Those are the old days.
more a question for Christensen, Mike, and Laura. No offense. Who have been doing this a little bit longer than me. All of the training and education that I have received is always IM versus sub-Q epi.
Of course, my memory could be failing me as well. But
So-
what is the deal with sub-Q? Why do I
So
remember that?
if you're talking about sub-Q epi, you're really talking a little bit about your age. So it's always IM now. There's no sub-Q really.
At least it's my age, not my memory.
Yeah, I don't mean